Good morning, everyone, and thank you for being here today. I'm excited to introduce our presentation on advancements in recurrent laryngeal nerve injury management. Today, we'll explore the latest evidence and strategies for managing this important complication, which is particularly relevant in thyroid and parathyroid surgeries. We'll cover nerve injury classifications, diagnostic tools, and the promising therapeutic potential of nimidipine. I look forward to sharing insights that could really impact patient outcomes. Let's get started. Now, let's talk about why RLN injuries are such an important concern. The recurrent laryngeal nerve, or RLN, plays a crucial role in controlling nearly all of the intrinsic muscles of the larynx. This means it's essential for voice production, swallowing, and protecting our airway. Because of this, any injury to the RLN can have significant consequences. What's particularly interesting and concerning is that even when the nerve looks intact during procedures like thyroid or parathyroid surgery, there can still be hidden damage. This hidden damage can lead to signal loss, or LOS, which then results in vocal fold paresis. In terms of how common this is, studies show that RLN injuries happen in about 3 to 8% of cases, and transient vocal fold problems can affect up to 9.5% of patients. The tricky part is that some of these injuries, even if they resolve initially, can persist beyond 6 months. And in rare cases, the paresis can become permanent, occurring in roughly 0.3 to 3% of cases. So, understanding these risks highlights just how vital careful nerve management is during surgery, and it underscores why we're focusing on this issue in the overall presentation. Now let's delve into the different types of nerve injuries and what their prognosis looks like. First up is neuropraxia, which is essentially a conduction block. In this case, the injury affects the myelin or the nodes of Ranvier, but importantly, the axon itself remains intact. Because of this, recovery is usually quite good, often resolving within just a few weeks to months. For example, a study by Hidman and colleagues looked at 15 patients with conduction block and found that all of them experienced full resolution, which is quite encouraging. Moving on, we have acsonotemesis. Here, the damage extends to the axon itself, but the nerve sheath stays preserved. This makes recovery a bit more complicated. It's slower and less predictable. Sometimes the reinnervation can go awry, leading to a condition called synkinesis, where nerves reattach incorrectly. Interestingly, treatments like nimidipine have shown promise in such cases, with many patients regaining full or near-normal function, according to research from PubMed and other sources. Finally, there's neuritemesis, which is the most severe form, complete transection or cutting through the nerve. Without surgical repair, this usually results in permanent issues like vocal fold paralysis. However, with microsurgical grafting combined with medications like nimidipine, there's a chance to restore function. The key takeaway here is that early and appropriate intervention can make a significant difference in outcomes, even in the most severe injuries. Now, let's delve into some of the key diagnostic tools we use during surgery to protect the recurrent laryngeal nerve. One of the most important is continuous intraoperative neuromonitoring, or CONM. This technique provides real-time electromyography, or EMG, feedback on the nerve's function. If we detect a loss of signal, or LOS, we don't rush ahead. Instead, we pause the operation for about 20 minutes to see if the signal returns. This pause is crucial because it helps us distinguish between a temporary conduction block, which might resolve on its own, and a more severe nerve injury, like axonal damage. The immediate feedback from CONM allows us to make informed decisions on the spot, potentially preventing bilateral vocal cord paralysis, which can be devastating for patients. Moving beyond the operating room, we also use electromyography and laryngoscopy to assess nerve recovery after surgery. Postoperative EMG helps us classify the type of nerve injury more precisely, giving us insight into whether the nerve is recovering or if there's ongoing damage. This is complemented by serial voice assessments and laryngoscopic exams over the course of 6 months. These follow-up evaluations are essential. They help us monitor the patient's recovery trajectory and determine if further intervention might be necessary. Altogether, these diagnostic tools form a comprehensive approach, allowing us to protect nerve function during surgery and optimize patient outcomes. They embody the integration of technology and clinical follow-up that's central to safe, effective thyroid and parathyroid surgery. Now, let's take a closer look at nimidipine and how it might help in nerve regeneration. Essentially, nimidipine is an L-type calcium channel blocker. What this means is that it helps regulate calcium entry into nerve cells, which is a key factor in nerve repair processes. By doing this, nimidipine promotes axonal sprouting, encouraging nerves to grow back and reconnect more effectively. Additionally, it helps stabilize the functions of both neurons and Schwann cells, which are crucial for nerve repair. Importantly, nimidipine also reduces maladaptive reinnervation, meaning it can help prevent abnormal nerve growth that might cause issues down the line. Looking at the evidence from animal studies, particularly in rat models of recurrent laryngeal nerve crush injuries, nimidipine has shown promising results. It significantly improved reinnervation of specific muscles, like the posterior cricoarytenoid, and increased neuron counts in the brainstem, leading to better functional recovery at around 6 weeks. Turning to human data, several clinical trials have been conducted. For example, in a 2009 study, patients with acanthomesis who received nimidipine experienced full recovery of vocal fold motion. Then, there was an open-label trial in 2013 where 60% of treated vocal folds regained purposeful movement, a substantial improvement compared to about 20% in historical controls. In a cohort treated with microsurgical repair plus nimidipine over 2 to 3 months, none of the 19 patients showed vocal fold atrophy over 3 years, and they demonstrated improvements in voice quality measures and some regained visible movement. Finally, a 2019 meta-analysis combined data from 9 trials, involving over 110 patients treated with nimidipine. The results were striking. The odds of recovering vocal fold motion were over 13 times higher, and facial nerve recovery was nearly 3 times higher compared to controls. Overall, these findings suggest that nimidipine could be a powerful adjunct in promoting nerve healing and functional recovery. Now, let's walk through the practical treatment algorithm we follow during and after surgery. First, intraoperatively, we utilize continuous intraoperative nerve monitoring, or CONM. When a loss of signal occurs, we stop and wait about 20 minutes to see if the nerve recovers. This approach helps us differentiate between a conduction block, which might resolve, and more severe nerve damage. It guides us on whether to proceed, stage the procedure, or even halt if necessary. Moving to the immediate post-operative period, within the first 2 days, we perform electromyography and laryngoscopy. These tests help us classify the type of nerve injury, whether it's a transient neuropraxia or something more severe. Then, during follow-up over the next several weeks to months, we monitor EMG, voice handicap index scores, maximum phonation time, and repeat laryngoscopy. This ongoing assessment helps us track natural nerve recovery or determine if further intervention is needed. Now, depending on the injury type, our treatment strategies differ. For acanthomesis, which is a more severe but potentially reversible injury, we start nimidipine early, around 4 to 6 weeks post-op, and continue for up to 3 months. This medication enhances nerve reinnervation and improves functional recovery. In cases of nerve transection, where the nerve is completely severed, microsurgical repair is necessary. We also administer nimidipine for 2 to 3 months post-surgery. Clinical studies have shown that with this approach, patients can experience normalization of their voice and function, often over a period of 1 to 3 years. So, this algorithm provides a structured, evidence-based pathway to optimize nerve recovery and patient outcomes after thyroid or other neck surgeries. Let's take a closer look at some key takeaways from our discussion. First, the type of nerve injury really matters when it comes to prognosis. For instance, neuropraxia generally has an excellent outlook, often recovering fully with minimal intervention. Acanthomesis, on the other hand, has a more variable recovery, but we've seen that the use of nimidipine and electromyography monitoring can really help improve outcomes. And then there's neurotmesis, which typically requires surgical repair and medication to support recovery. Now, an essential point I want to emphasize is the importance of intraoperative neuromonitoring, or IONM. This tool allows us to get real-time feedback during surgery, which is critical. It significantly reduces the risk of bilateral paralysis because we can make immediate decisions if nerve function starts to decline. Essentially, it acts as our safety net, helping us protect vital nerve functions throughout the procedure. Moving on, I want to highlight the strong evidence supporting nimidipine. Multiple studies have shown that this medication has a powerful effect on nerve recovery, especially for vocal fold and facial nerve motion. It's not just promising in theory. The research backs up its therapeutic value, making it a key part of our treatment arsenal. Finally, regarding safety, nimidipine is generally well tolerated by patients. Of course, like any medication, there can be side effects, most commonly hypotension or dizziness. That's why monitoring during therapy is so important. It helps us ensure patient safety, manage any adverse effects promptly, and ultimately optimize recovery outcomes. So, to sum up, understanding the type of nerve injury, utilizing intraoperative neuromonitoring, leveraging the benefits of nimidipine, and maintaining vigilant safety measures all play vital roles in improving patient care and recovery in nerve injury management. Now, let's look at some of the future directions and open questions in this field. First, the timing of when to start nimidipine treatment is still not fully standardized. We need more research to determine the optimal therapeutic window. What's the best moment to begin treatment to maximize recovery? Next, establishing the precise dose-response relationship is critical. Knowing exactly how different doses affect outcomes will help us fine-tune therapy for each patient. Another important area is understanding nimidipine's role in different types of nerve injuries, especially crush injuries versus nerve transections. Clarifying this will help us tailor treatments more effectively. Lastly, while early results are promising, we really need large-scale, randomized controlled trials. These robust studies are essential to validate the benefits we've seen so far and to confidently integrate nimidipine into standard clinical practice. Overall, these open questions highlight the exciting potential of nimidipine, but also the work that remains to ensure we use it in the most effective and evidence-based way possible. As we come to the final slide, I want to highlight the key takeaways from Mattson's work on managing recurrent laryngeal nerve injuries. His approach is quite comprehensive and really underscores how integrating advanced diagnostic and therapeutic strategies can make a significant difference. One of the core components is real-time intraoperative monitoring, which allows us to detect nerve issues as they happen, giving us the chance to intervene immediately. This proactive approach helps prevent more severe damage and improves outcomes. Another critical aspect is accurate injury classification through electromyography, or EMG. This technology helps us understand the extent of nerve injury with greater precision, guiding our treatment decisions more effectively. Additionally, the strategic use of nimidipine, a medication known for its neuroprotective properties, plays a role in promoting nerve recovery and reducing secondary damage. When you look at the overall picture, this multifaceted strategy, supported by solid preclinical and clinical evidence, really offers hope for better recovery rates in patients suffering from RLN injuries. It's about combining technology, pharmacology, and clinical insights to optimize patient care and outcomes.